Welcome, all friends, all interventional cardiologists, CT operators. I would like first to thank IMDS for this kind invitation for this webinar. So the subject is very interesting for me because it changed all my Antegrade strategy in CTO now, and I want to share you my feedback on this new device whose name is ReCross, and I want to tell you why and how ReCross modified some of my strategy on CTO operation. So first, what is ReCross? So ReCross is a dual lumen microcatheter, but it's even more than that because it's a dual over-the-wire microcatheter. All the dual microcatheter we had actually in the market, you have one monorail wire and one over-the-wire wire. And here the particularity of the ReCross is that you have two over-the-wire port, and that makes all the differences between this one and all the other one. That's why for me it's not another dual lumen microcatheter, it's a new device. And so you have two enter, the blue one and the white one, and you have three exit points, a distal one and also two lateral opposite exit. In practice, what is it like this? So there is a steel part inside the blue part. So you remove it. It's like the thromboaspiration. Then, so I will go with my wire inside the blue one. And the blue one, you will see, will deserve only the lateral port. Okay, so blue one and exit lateral one. Then I go to the white one, and the white one is able to get inside the distal part, as you can see. But also, if you remove a little bit the wire and turn it, you can exit to the opposite lateral port, opposite from the blue one. So this is very interesting because with one dual lumen microcatheter provide you three different exits. So that's why this device is very, very new. So to summarize, if you go with your wire in the white port, you can exit from the distal part, so you can see the white star, but also a lateral one, proximal one. This is a second white star. And if you go with your blue port, you will exit in the mid part, lateral port. So the question is a ReCross only one more dual microcatheter or not? For me, you can understand it's even much more than that. So everyone knows what is the interest of a dual lumen microcatheter. I will show you this example, an example when the ReCross was not already in the market. So it, as you can see, it's a very angulated bifurcation between LED and diagonal. My wire is only going on diagonal branches, impossible to get inside the LED. So you can understand with this very angulated part. So we decide to work with a dual lumen microcatheter, which was not the ReCross. And the interest of this dual lumen microcatheter is first to increase the pushability, but also to straighten the bifurcation, and then to use a second wire to get inside the LED. So that's what we've done. So it's a soft wire, it's a scion wire. You can see the angulation now very well, and you can see that my wire in the margin, in the diagonal branch, is in the monorail part of the dual lumen microcatheter. So I summarize. My wire is only going on the diagonal branch. So I want to use a dual lumen microcatheter. So I use my diagonal branch, the monorail part of the dual lumen microcatheter. So I came with my double microcatheter here to straighten the bifurcation. Then I can use a soft wire just to enter inside the LED. But you can see here the angulation between the LED and the diagonal. And the point is, my LED wire enter inside my dual lumen microcatheter with the other over the wire part. So I try to advance it more, but then I have a lack of support here. And the wire was unable to get deeper inside the LED. So what next? Here, the only way was to remove this dual lumen microcatheter and to open a new microcatheter to increase the support inside my LED wire and to get deeper with my wire inside the LED in the distal part. But at that time, if the ReCross was available, I can switch my ReCross as a dual lumen microcatheter to a microcatheter and use only one device to finalize this case. So here I was only able to open another microcatheter to finalize. So that's why the ReCross changed everything in my practice. But I can tell you, what are the special use of the ReCross and why I use it? First, this is the only one with enhancer RX which are able to be trapped in 6 French. All the other one, Find You, Sasuke, or the other one are all trapped in 7 French. The only one we can trap in 6 is a ReCross and enhancer RX. First, I use it a lot to increase my anchoring technique. Actually, what was my anchoring technique? The usual one. You can see that it's a very small ostial RCA, and my left implants are not so well coaxial, and my support is not so good. So at that time, what is my anchoring technique? It was like this. It means put a wire in the marginal branch and a balloon, and then go with a parallel wire on a microcatheter to puncture the CTO proximal cap. But now we can do different with dual lumen microcatheter. We can do it with all dual microcatheter. So, for example, the old fashion with dual lumen microcatheter. You have your side branch and you have your proximal cap. Then you get inside the side branch with the distal part of your dual lumen microcatheter, so monorail 1, and then you try to puncture with your over the wire part of your dual microcatheter to puncture the proximal cap of the CTO. But then when your wire is going inside like this, what next? You are blocked. It means the monorail part block your dual lumen microcatheter at the entrance of the CTO segment. So what is the advantage to use the ReCross as an anchoring devices and also increasing support to puncture the proximal cap of your CTO? This is an example. This is a proximal RCA. You can see mid RCA blunt cap, little bit calcified, and the final is at a bifurcation point. There is some retrograde filling, so my plan was Antegrade first because the length of the CTO was not so long, and in case of failure, go retro via septal connection. So then I use now the ReCross. So what the ReCross will give me? So I used the side branch to increase my support, but I use a wire inside the side branch via the lateral blue port. Then the nose, the tip of the ReCross will point in the direction of the proximal cap. And I can get inside the other over the wire part, so the white one, distal white one, with my CTO wire. And the point is, when my CTO wire enter the core, the body of the CTO, then I can remove my lateral one to switch my dual lumen microcatheter as a microcatheter. This is our example. So you can see I have one cyan blue in the side branch and a Confianza Pro 12 inside the distal white exit to puncture. Then I puncture inside the CTO, so I don't need anymore my anchoring wire. So I will remove it, and I can do it because I'm using a ReCross, and it is the only one which use 2 over the wire port. It's not a monorail, so that's why I'm free to remove this wire. Then I use the ReCross as a microcatheter. You can see now the tip of the ReCross is inside the CTO body, and I can switch my CP12 for a Gaia third, and then use it ReCross as a microcatheter, a regular one. And this is a final result. What next? Next is the parallel wire technique. Everyone knows this technique. It's a very useful technique when you are antegrade. So the technique is your first wire with your microcatheter is subintimal. So what next is to remove the microcatheter, let in place the first wire and go back with the same microcatheter and try with the second wire to get inside the true lumen using the first wire as a marker. So this is an example of my old fashion now of parallel wire technique. You can see circle occlusion, short one, so it's a good Antegrade strategy. It seems to have some micro channel. So I went with my first wire, which were feeder XT, and unfortunately my wire were subintimal. So it was not the time of the ReCross. So the point is I want to do parallel wire technique. So I have to trap my first wire, remove the microcatheter, go back with the microcatheter and a workhorse wire in front of the proximal cap, and puncture with another wire and try to be parallel to the first one, but a little bit more on the right. So all that maneuver was not so good. So that was the final result with the parallel wire technique. So now what I'm doing with my actual parallel wire technique, with the ReCross. What I explained to you is now I'm using the ReCross as my first microcatheter when I think that I'm going antegrade and maybe my first wire could be subintimal. And so I'm ready to use the ReCross as a parallel wire devices. So for example, it was a very special case, very interesting case. The guy was suffering from angina, and the diagnostic angio never find the ostium of the RCA. And when you see, you inject the left coronary, you can see that the left coronary have some feeling from LAD to circ and circ to RCA. And then we have done MSCT, and MSCT confirmed that these guys were an agenesis of ostium of the RCA, and the RCA birthed from the circ. So it was a very complex case. The retrograde was not so easy. So in that point, as you can see on the second video, there is some micro channel on the stump. There is a stump on the proximal cap. So the Antegrade strategy was the best one in that situation. So I went with a ReCross as a first microcatheter and use with the distal white port a feeder XT. And as you can see, the feeder XT can get inside an obtuse marginal branch very easily. So I advance my ReCross as a microcatheter in front of this bifurcation between circ and marginal, and then use the Antegrade dual access, and with the lateral blue port use a Gaia third and use a ReCross also as an anchoring part. Then I can make some progression with my Gaia in the direction of the distal part of the circ. Unfortunately, as you can see, my Gaia was subintimal. So in that situation, I was with the distal white Fielder XT in the marginal and the lateral blue with the Gaia third. So what next? If I am using a usual dual microcatheter, I'm finished. I'm stopped. I can use it. Nothing. I can't advance the devices. But this is a ReCross, and we have two over-the-wire port, and I'm free to use everything and to remove everything. So what I did is I remove my Fielder XT, advance a little bit the ReCross, and use the distal white part with another Fielder XT to redirect it parallel to the Gaia third and try to use it as a parallel wire technique. Unfortunately, the XT was not able to get inside the true lumen because it was too soft. Then I remove it for another Gaia third, and then the Gaia third was able to penetrate the true lumen, as you can see. And I use my first Gaia third as a marker. You can see is upper to the true lumen, and the second one was inside the true lumen. So what next? If I am using a usual dual lumen microcatheter, I'm stuck. I just need to let in place my wire in the true lumen, remove the dual microcatheter, and go back with another microcatheter, a regular one. But here, no. I just pull back my first Gaia third, which is subintimal, and use the microcatheter. And then go with a scion wire. You can see scion went first in the lateral white one and then distal white one, and go inside the RCA. I can see you again. You see the scion is going up, is going to the lateral one. Just remove it, turn it a little bit, and go to the distal white one and go get inside the RCA. So now I have to protect my bifurcation between circ and RCA. So I used the ReCross also as a dual lumen microcatheter and went with another scion wire in the lateral blue exit. And you can see it went very easily inside the circ. This is angio, and this is the final result. So you can see that the circ, it's a specific anatomy where the circ gave the RCA, but also the distal circ. We controlled this patient 6 months later, and the result was really perfect. So I want you to understand why for me the ReCross is unique and is only one device is like this. This is a guy who make a cardiac arrest. He was resuscitated, and the diagnostic angio shown at the time 2 CTO, RCA CTO and SIR CTO. We did at the first part Antegrade lead RCA CTO, and 2 months later we did the circ. So this is the circ CTO. You can see the double injection. The circ CTO is very close to the ostium of the circ. The length of the CTO seems to be around 20 millimeter. There is some stump. So we decide to go Antegrade lead. And but because I'm not sure that my first wire will be true to true lumen, and also because if you can see the distal part of the circ is ending with a bifurcation with a big marginal, I decide to use a ReCross as my first microcatheter. So I went first with a Miracle 6 on the ReCross. Why Miracle 6? Because as you can see, it was a very proximal CTO part. And if I get with a Fielder XT or a Gaia, the support will be not enough to advance my microcatheter. That's why in that situation, I'm still using Miracle wire. So the Miracle went well. You can see advance seems to be close to the distal cap. So it's still the Miracle with the support of the ReCross. And the Miracle makes some progression. And finally, the Miracle went inside the true lumen of the circ. But I don't want to lose the big marginal branch. So what next? I advance my ReCross, and you can see that the profile of the ReCross is very good. And the ReCross went very easily inside the CTO segment, was placed in front of the bifurcation. I try first with a Scion wire to get inside the marginal, but unfortunately, there was some subintimal tract at this part and some flap, and my Scion was unable to get inside the marginal. So I place the Scion wire in the distal part of the circ, as you can see. So I'm in the branches, and now distal part of the circ. And then my point was to reuse the Miracle to get inside the marginal branch. And I can do it because of the ReCross, and because the ReCross has 2 over the wire entrance. It's impossible with any other dual lumen microcatheter. And so with the same Miracle, I am able to puncture this small flap and get inside the true lumen of the marginal branch. And this is the final result. And you can see we have all the branches of this circ, and the patient went well. Then you have also other utilization of the ReCross. One is to use it as a re-entry device. It's a dual lumen microcatheter, but remember that you have two opposite exits, the blue one on the left and the white one could be distal or lateral one on the right. So you can use it if your ReCross is subintimal and you are able to direct it in the space just down or up to your true lumen, you can use it as a re-entry device. I can show you an example. So this is a long RCA CTO. Distal port are a little bit diseased, and the retrograde was not so good. Only epicardial one, very tortuous. So my strategy was first try Antegrade, and if not, go for ADR. But my point was go to ADR with Stingray. So then I puncture. So this is a ReCross with a feeder XT wire. So with the ReCross, I have a lot of support to advance my knuckle. And the feeder XT knuckle went inside the CTO body. As you can see, knuckle is coming up. Then I am able to advance now the knuckle. You can see that I'm dancing, the knuckle is dancing with the distal part of the RCA. So I'm advancing the ReCross. And then at this point, I said, okay, I will go with the ReCross and try to get inside the true lumen with the lateral is to be sure with different projection to be in the good position, in a good space to know if you need to puncture up or down. So with a Gaia third in the lateral blue exit, I puncture inside the true lumen and advance it very well. And this is the control, and this is the final result. So this is a good demonstration where you can use it if you are, you know, Stingray is a very good device, but it's very expensive. And not all the cath lab and not all the countries are able to get a Stingray wire, a Stingray catheter in their cath lab. So ReCross is a good point. It is a good re-entry devices if you can use it Stingray. Second use of the ReCross is because of the two over the wire. You can use one to decompress an hematoma, or you can use it also to do a tip injection. It's impossible with a dual lumen microcatheter, the other one, because you have a monorail entry and you can inject inside the monorail. To conclude, I can tell you what I have done in my last 106 last cases, which were my first intention strategy. You can see that more than 67% was an Antegrade, 9% ADR, and 24% retrograde. In my 72 last Antegrade cases, what was my final successful strategy? In 41%, my first wire went through LUMEN. So it means that I have chosen the right wire to use only one wire for my CTO procedure. So in 59%, sorry, my first wire was subintimal. So in that situation, what was my successful strategy? In 15% of cases, I was successful by switching wire for a stiffer one or a polymeric one. In 20%, I was successful by doing parallel wire technique with the ReCross. In only 6%, I switched for ADR with Stingray. And in 19%, I went retrograde.
So, Dr. Avran, we have a question for you if you have a second.
Yeah, sure.
Yeah. The question is it possible to torque ReCross to redirect your re-entry?
No, but you don't need, because you have two opposite exit. So it means if your first, for example, you used the blue one exit, and the wire is going not where you want it to go, then you can let the wire in place and go with the white entrance and go lateral with the white, and then you are opposite to the blue one. So you don't need to turn it because you have two different opposites. For example, the Stingray catheter, you don't turn it also because you have the two opposite exit. And for the ReCross, it's the same. You don't need to turn it. Is it good?
Yes, thank you, Dr. Avran. That's a good answer. Very, very helpful. Thank you.
To finalize my discussion about my last 100 cases, I just ask myself the relationship between my initial CTO lengths and my Antegrade successful strategy. And I can see that if my first wire is going through LUMEN, the length of my CTO was around 90 millimeters, so less than 20. When my first wire is subintimal, the length of my CTO is longer, and my successful strategy by switching for a stiffer wire, the average of length of my CTO is around 20-21. But when I'm using the parallel wire technique with the ReCross, you can see that the average length of my CTO is longer, 27.5. It means that with the ReCross and with the parallel technique using the ReCross, I'm not inside the hybrid algorithm where the guy says, no, your CTO length is more than 20, you have to go ADR, straightforward, or retro. But you can see that with the parallel wire technique and the ReCross, my success rate is very high. and the average length of my CTO could be more than 25 millimeter, 27.5. So it was a very interesting study that I did with my cases, but I think it's the case for everyone, and you can use it in your next Antegrade attempt. So just to conclude, this is my last case I did last week. So it's RCA. The length of the CTO seems not to be very, very long, but it's a tortuous one. So we try Antegradely. So now you can see all my steps. So I use a ReCross as an anchoring devices. So a cyan wire inside a side branch, and Gaia third in the distal white to puncture the proximal cap. So from now everything is good. I advance. It seems to be good, but the Gaia is subintimal at the distal cap because of the tortuosity of this. I remove the wire inside the side branch and advance the ReCross as a microcatheter inside the CTO segment. Then I can switch my CTO wire if I want, or I can use it now as a parallel wire devices and use a second Gaia third exiting from the lateral blue one and try to get inside the true lumen. So you can see that the second Gaia third made a good track, but unfortunately you can see the tortuosity of the vessel, but the second wire went also subintimal. So at this part, after different attempts, I decided to switch my strategy to a ADR1. So also with the ReCross, I went with a Fielder XT and the distal part and knuckle it. Up, and the knuckle, you can see all the tortuosity of the vessel. And my point was to use the ReCross as a re-entry devices. But fortunately, I think that my knuckle seems to be in the true lumen. So it's Fielder XT wire. So I just remove the knuckle from the XT and try to get inside. I was pretty sure that I was inside. So I advance my ReCross and use the ReCross as a tip-in devices. So for a tip injection, then I'm sure that I am inside. You can see the bifurcation with the PDA and RV branch. So I will use my same ReCross as a dual lumen microcatheter and place a wire inside the PDA and another one inside the RV branch. And this is the final result. So to conclude, finally, I hope you understand why the ReCross modified all my Antegrade strategy in the CTO operation. Now I'm using the ReCross if I have an Antegrade CTO attempt with a length more than 20 millimeter. You can see that the average length of my CTO successfully with the ReCross was 27.5. And I'm also using the ReCross as a first microcatheter when I want to go antegrade, but I'm not sure that my first wire will cross through lumen. And if my wire went subintimal, then I can use the ReCross as a parallel wire devices. I use the ReCross as the first microcatheter when my proximal cap is close to the side branch, because anchoring technique increase your support, increase your pushability. And also when I have a distal cap at a bifurcation point. I hope this was very clear for you. I still want to thank IMDS for this webinar. I just invite you for the next EMLCTO. You understand the pandemic situation, so we are doing MLCTO on the web within CatLab. It's a free subscription. You have just to subscribe in CatLab website, and you can see all the live, all the tips and tricks we have made for you, the teaching point. We have 5 live this year. You can see it in direct or in streaming when you want, but you need to subscribe. Thank you so much and see you soon. And if you have any question.
There is a second question, Dr. Avran. Going back to part of your earlier discussion, the question is, with the Stingray device, the ports orient facing the true lumen. What is your strategy to orient ReCross so that one of the ports faces the true lumen?
So the point is, like the Stingray, we don't know if the port is facing the true lumen. Okay, what we want, we need to find a projection with the Stingray where the 2 lines on the 2 points, the 2 lines are parallel. Okay, it means that you can see the Stingray in profile view. So you have to find a projection, and with the ReCross it's a little bit the same. You have to find a projection when you can see that the ReCross devices is just on the right side or downside. It depends the projection of the true lumen, and then you just choose the lateral exit you want. So it's a little bit like the Stingray manipulation. So you don't need to torque it. You just need to find a projection, because if you are using a knuckle, you are sure to be in the architecture of the vessel. Okay, so you are down or up from the vessel, or right or left. Then you have just to choose a projection to see if you are right or left. It's not so easy to explain, but it's easy to do.
Thank you, Dr. Avran. I think that's a clear description.